Now, the periodontitis as a manifestation of systemic disease. Periodontitis as a manifestation of systemic disease, it can be divided into two categories. Those which are associated with hematological disorders such as leukemia and acquired neutropenias, and those associated with genetic disorders such as familial cyclic neutropenia, Down syndrome, Papillon-Lefevre syndrome, hypophosphatasia. Although the primary etiological factors in the periodontal disease is bacterial plaque, this patients presents with fair to poor prognosis. Because of the presence of the systemic disease, there will be aggregation of the multiple factors and multiple genetic factors, such as which increases the risk of periodontitis, and there will be downgrade shift of prognosis from fair to poor. Periodontitis is a manifestation of systemic disease, also includes the hypophosphatasia, where the patients have decreased level of circulating alkaline phosphatase, severe alveolar bone loss, premature loss of deciduous tooth, and permanent teeth, and connective tissue disorder. The prognosis will be fair to poor. Necrotizing ulcerative periodontitis, in which the alveolar bone, and necrotizing ulcerative periodontitis, if it is involved and if it involves the gingiva only, then it is called as necrotizing ulcerative gingivitis. In necrotizing ulcerative gingivitis, the primary predisposing factor is bacterial plaque. So, such as acute psychological stress, tobacco smoking, poor nutrition, all of which can contribute to the immunosuppression. The prognosis for such a patient with the necrotizing ulcerative gingivitis is good, and the tissue destruction in these cases is not reversible, and poor control of secondary factors may make this patient susceptible to recurrence of the disease. With repeated episodes of necrotizing ulcerative gingivitis, the prognosis is downgraded to fair. So, tissue destruction is not reversible. So for the patients having the nerve and patients having the nerve will having the poor prognosis as compared to nerve. You can see the inflammatory response in the gingiva, and you can see the inflammatory response in the tissues also. Like you can see the ulcerative, necrotizing ulcerative gingivitis, and after the treatment. The clinical presentation of necrotizing ulcerative periodontitis is similar to that of necrotizing ulcerative gingivitis, except that the necrosis extends from gingiva into the periodontal ligament and alveolar bone. So many patients presenting with the necrotizing ulcerative periodontitis are immunocompromised through systemic conditions such as HIV infections, and in these areas, you can see the prognosis is dependent on not only reducing the local and secondary factors, but also on dealing with the systemic problem. So here you can see that the patients who are immunocompromised has unfavorable prognosis because of the systemic conditions involved, such as HIV infections, because the neutrophil counts, the T lymphocytes, B lymphocytes, they are decreased. And here you can see that the amount of bone loss, and here also, so here in these cases you can assess the individual prognosis also and overall prognosis. Overall prognosis is somewhat fair, but individual prognosis is poor because of the amount of bone loss. So this is the determination of prognosis. Now about the treatment plan. So what happens in the after the diagnosis and prognosis? The third stage is your treatment plan. After the diagnosis and prognosis have been established, treatment is planned, and the treatment plan is a blueprint for the case management. It includes all the procedures which is required for the establishment and maintenance of oral health. So treatment plans also includes the following decisions: the teeth which is to be extracted and teeth which is to be saved. Periodontal pocket therapy techniques, which include surgical and non-surgical, that will be used. Occlusal corrections before, during, and after the pocket therapy, the use of implant therapy, the need for temporary restoration, final restoration that will be needed after therapy, and which the teeth will be abutments if a fixed prosthesis is used, the need for orthodontic consultations, endodontic therapy, decisions regarding the aesthetic consideration in periodontal therapy, and the sequence of therapy. So basically, and the treatment plans includes all the decisions, even the sequence of therapy, which treatment has to be performed first and which treatment has to be performed lately. Occlusal correction before and during the after pocket therapy. And the use of the implant therapy also, you need to, what is the master plan for the total treatment? What is the master plan? The primary goal is the elimination of gingival inflammation, correction of the condition that cause and perpetuate it. This includes not only elimination of the root irritants, but also pocket eradication and reduction, establishment of gingival contours, mucogingival relationships, conductive to preservation of periodontal health, restoration of the carious areas, and correction of the existing restorations. Because the re-establishment of the proper gingival contours and mucogingival relationship is also critical, because to preserve the periodontal health, and you have to recorrect the existing restorations and existing carious teeth also. Now, when to perform extraction and when to perform preservation. So treatment is directed to establishing and maintain the health of periodontal throughout the mouth, rather than to spectacular efforts to tighten the loose tooth. So remove retention or temporary interim retention of one or more teeth is very important part of overall treatment plan. So what happens? Treatment is basically established to maintain the health of periodontium and health of periodontium in full mouth. So individual prognosis is also assessed, but overall prognosis is assessed and overall treatment is performed to overall mouth. So basically, overall treatment plan is very necessary. A tooth which is to be extracted, if they have, it is mobile and function has become painful. It is so mobile means mobility, you can divide it into the grades, grade 1 mobility, grade 2 mobility, and grade 3 mobility. For the simple language to understand, grade 1 mobility is mobility only in the one direction, like only in buccolingual direction, only in the mesodistal direction. But if mobility is like in all of the four directions, buccolingual plus mesodistal, is grade 2. And in grade 3, there is axial displacement of the tooth also, apical also. It can be pressed in the socket. If there is so much periodontal pus, so it is very painful also, and it can patient cannot perform the functional activities with such kind of mobile tooth. So this such kind of the tooth has to be extracted. Now it can cause acute abscess during the therapy, and there is no use for it overall treatment plan. So a tooth which has to be kept has put some role in the mouth, like for the impacted eight and for the like if antagonistic eight is missing. So you have to assess if the tooth has no use in the oral cavity and in the no overall treatment plan, then you can remove it. And if it is like if the presence of the some tooth can cause the abscess, then you have to remove it. So you have to make decision which tooth has to be retained and which has to be extracted. A tooth can be retained temporarily, postponing the decision to extract it until the treatment when any of the following occurs. First is it maintains the posterior stop. The tooth can be removed after treatment when it can be replaced by prosthesis. Means it acts as a posterior stop because the cantilever bridge is not very successful, and the tooth can be removed after the treatment. It maintains the posterior stops and it may be functional after the implant placement. In adjacent areas where the implant is exposed, this tooth can be extracted. See, for such kind of the tooth, imaging plan can be formed, and until that case is, then you can place the tooth in the position, and afterwards you can remove this tooth. In anterior aesthetic areas, a tooth can be retained during the periodontal therapy and removed when the treatment is completed, and permanent restorative procedure can be performed. Removal of hopeless tip can also be performed during periodontal surgery of neighboring tooth, and this approach reduces appointments for the surgery in the same area. So what happened, you have to remove the hopeless teeth, and basically what happens, the hopeless teeth, this aids in a function, uh, because you can like get more accessible areas, and also it reduces the appointments for the surgery in the area. In complex cases, interdisciplinary consultation with other specialty areas is necessary before a final plan. The opinion of orthodontist and prosthodontist is also important because of the consideration of occlusal relationship may be in order and may necessitate occlusal adjustment, restorative, prosthetic, and orthodontic procedure, splinting and correction of bruxism, clamping and clenching habits. Systemic conditions should be carefully evaluated as they require special precautions. Supportive periodontal care, it consists of instructions in oral hygiene and checkups at regular intervals. Occlusal relationship consideration is very important because in the treatment plan you may require the occlusal adjustment, you need to correct the bruxism, you need to correct the orthodontic procedures and all the habits and everything, and you need to control the systemic conditions also. Now, this is very important. The phases of treatment plan, which includes preliminary phase, then non-surgical phase, phase one therapy, then surgical phase, which is also called as phase two therapy, restorative phase, which is phase three phase, and maintenance phase, which is known as phase four. So basically, the phases of periodontal therapy consist of 5 phases. Now the preliminary phases. Preliminary phases is also called as emergency phase, means where here we are going to treat the emergencies. So they can be the dental or periapical abscess, periodontal abscess, or others means the extraction of hopeless teeth, and provisional replacement if needed may be postponed to the more convenient time. So if the patient has come with the dental or periapical abscess or periodontal abscess, you need to drain it out in first setting, whether because patient is complaining of the pain. So all this extraction of hopeless teeth, all this will come under the emergency phase. Now the non-surgical phase, phase one, which is also called as etiologic phase or non-surgical phase or hygienic phase. So which includes the plaque control and patient education. So diet control in patient with the rampant caries, removal of calculus and root cleaning, correction of restorative and prosthetic irritational factors, excavation of caries and restoration, antimicrobial therapy, local and systemic occlusal therapy, minor orthodontic movement, provisional splinting and prosthesis. So basically, all those things we need, we can do in non-surgical phase. First of all, patient is assessed about the patient is also motivated to perform oral hygiene instruction carefully. The correct brushing technique has to be teach in this phase. All the habit is has to be like to quit the habit if the patient has a smoking, and even the minor surgical movements, orthodontic movements, and provisional splinting, antimicrobial therapy, all those things which motivate the patient to maintain the proper oral hygiene is come under non-surgical phase. Now, evaluation of response to non-surgical phase. Rechecking if patient is recalled after 7 to 10 days after the phase 1 therapy, because you need to evaluate. You are going to check the gingival condition of the patient. You are going to check the periodontal condition of the patient. So, by how will you check it out? By seeing the color, consistency, bleeding, on probing, any pus, any sign of inflammation on gingiva, and by checking the pocket depth and gingival inflammation for the periodontium. So after like your phase 1 therapy is satisfied, you can go on the next phase, that is surgical phase. So phase 2 is your surgical phase. Periodontal therapy includes replacement of implants, Endodontic therapy. So surgical phase can be done if you are going to reassess the gingival and periodontal status. If the periodontal status is not maintained in the non-surgical phase, you are going to perform the periodontal therapy. Periodontal therapy, like you are going to perform the pocket reduction therapy, you are going to perform flap surgery, regenerative surgery, implant placement, and for the hemi section, root resection, everything you are going to perform on the surgical phase. And endodontic therapy, the root canal therapy, apicectomy, and the excision of the cells, tumors, all this come under the surgical phase. So surgical phase and restorative phase are side by side. This is not necessary. The first surgical phase is 2 and the restorative phase is 3. Mostly this forms a mutual interaction. So restorative phase is your phase 3, final restoration, fixed and removable orthodontic appliances, evaluation of response to the restorative procedures, and your again periodontal examination. So what happened? You are going to give the final restoration, and you can give the fixed prosthesis, and you need to restore the evaluation of response, and again you are going to check the periodontal examination for gingival and periodontal stages. Maintenance phase, phase 4, you are going to check the this phase is very important. It is also for phase 4. You are going to check the any evidence of like after surgery and after thoracic screening, root canning, professional full mouth plaque control. So there will be a regular periodic rechecking of the patients depending upon the condition of periodontium. Like if more severe, the recall period should be smaller, and if the patient is stable, the recall period would be longer. So in general terms, like for the patients with the gingivitis, we need to recall the patients for every 6 months after the completion of the treatment. And for patients with the severe periodontitis, we need to recall the patients every monthly. And if the patient is stable, we can schedule the patient for the periodontal flap surgery. And afterwards, you can recall the patients for every 6 months. So when the patients uh, came for the periodic rechecking, you need to check the plaque and calculus. You're going to check the gingival condition, presence of pocket depth, presence of gingival inflammation. You're going to check the occlusion, tooth mobility, and you're going to see the pathological migration, the pathological changes. If the like gingiva is healed properly, there should not be presence of any like unhealing patches and everything. You need to check the any changes you have found. So this is your maintenance phase. Now, explaining treatment plan to the patient. This is very important. You need to be specific. You need to tell your patient you have this disease, because reporting to the patient is very much essential. Patient has suffered from any disease, like patient has, if you have diagnosed some diseases, some kind of systemic diseases, and you find some oral lesions, which is manifestation of systemic disease, inform patient whatever you see in the patient's mouth, and you do to tell what the condition is and how the treatment will be processed and what would be the prognosis. And you should avoid the vague statements. Like, what do you understand by vague statements? हाँ ये ठीक हो जाएगा, हाँ ये ठीक हो सकता है, नहीं, you best be specific. Just tell the patient if you're going to do that, the treatment will be fine, and if you're not going to not following the proper instruction, then you can suffer the consequences of the this thing. So begin your discussion on a positive note. Always, whenever you are discussing anything with the patient, you have to bring the patient to a point who can understand the every possibilities, and always explain the positive aspect of the treatment. Don't start on the negative. Like if patient has like there can be some poor prognosis for some tooth also, like one or two, but there will be a good prognosis for overall mouth. So explain with the positive note. You should talk about the tip that can be retained and long-term service they can be expected to render. Do not begin with a statement like the following teeth has to be extracted. Emphasize the important purpose of the treatment is to prevent the other teeth from becoming a severely diseased loose teeth. Present the entire treatment plan as a unit. Avoid creating impression that treatment consists of separate procedures, some all of which may be selected by the patient. Make it clear that the dental restorations and prostheses they contribute as much as health of the gums and inflammation of the um, and elimination of the inflammations and periodontal pockets. So पूरा treatment plan आपको you have to explain them as a unit, not like perio treatment अलग, prosto treatment अलग, not like that. All the because the surgical phase, restorative phase, and prosto these are the like everything goes hand by hand. So you need to clear if the restorations and prostheses also contribute to the elimination of inflammation, and you need to maintain the this also. Explaining then doing nothing or holding on to the hopelessly diseased teeth as long as possible is unadvisable. Why? Because of the following reasons. Because the periodontal disease is a microbial infection, it can be important risk factor for the severe life-threatening disease such as a stroke, cardiovascular disorders, pulmonary disease, diabetes, as well as premature low birth weight babies in the women of childbearing age. It is not feasible to place the restoration and bridges on the tooth with untreatable periodontal disease. Failure to eliminate the periodontal disease not only results in the loss of the teeth already involved, but also shortens the lifespan of other teeth. So, so tell them to save the hopelessly teeth and to spend more time on the hopelessly teeth is not uh, advisable because there can be chances of parental medicine. We have already discussed the two-way relationship of every disease because of the oral infection, because of the focus of infection. There can be chances the infection can be passed into your bloodstream and can affect. So it is not advisable, and prosthetic dentistry is also not possible on the periodontal weakened tooth. And if you're not going to eliminate the periodontal disease, there will be loss of tooth. So thank you. This is your treatment plan. Thank you very much.